So I just want to welcome everybody to the meeting. We have a good many updates because we received several questions this time through the forum, which is great. So I'm going to get started because we have limited time. Margaret, you're first on the agenda for HHS update, so I'm going to turn it over to you.
Great, thank you. Let me do a sound check. Can you hear me okay?
I can hear you.
Great. All right, so just a few updates to get started. We have been issuing quite a number of bulletins from the Medicaid agency. First and foremost, the HCBS rate updates. That bulletin did go out. That includes the updates that we're making to nursing services rates, as well as the waiver services. Those rate increases included adult day health care, home delivered meals, I mentioned nursing, nutritional supplements, pest control, and then the identified tiers of residential habilitation that were updated for July 1. So just wanted to call attention to that bulletin that has been issued. We have also announced a pretty substantive group of actions. Still have a couple of bulletins to make their way out the door, likely today or tomorrow. With regard to behavioral health, I wanted to make a couple of mention of services and updates that we are issuing. So for autism services, we are updating some additional codes for our ASD array of services. This will add some additional codes that are not currently available. It will complete the full array of ASD service codes for the state. And basically the codes that we're adding will allow for some additional services assessment when completed by a registered behavior therapist under the direction of a physician or other qualified health professional. It also will add some codes that will allow for multifamily group approach to adaptive behavior treatment. It also adds codes for assessment that is administered by 2 or more technicians, and then adaptive behavior treatment that is administered by 2 or more technicians. So those last 2 codes are really geared to allow for multiple technicians that may need to work with one member due to high complexity or the needs of that member. So wanted to make mention of those updates. We are also going to be updating our Medicaid targeted case management provider manual. Of course, we are lifting the moratorium that has been in place for new providers to enroll for Medicaid targeted case management, or MTCM. We currently had that limited to certain counties within the state that were identified as high need. So come July 1, we will be lifting that moratorium. For new providers, the bulletin, which is in final review, should be going out shortly, will update requirements for new providers upon enrollment that they will need to submit. There will also be some reference to prior authorization for private providers. So we do identify that for state agencies or those acting on behalf of state agencies, not all requirements will apply initially for those requirements for prior auth. And for those individuals that are already receiving Medicaid targeted case management, we intend to phase in that prior auth requirement over the course of time. Currently, policy requires that a reassessment be completed every 6 months. So we intend to cycle through and add those requirements as individuals come due for their 6-month reevaluation or reassessment for TCM. There will be some prior auth requirements for anyone that is new to receiving TCM. So certainly as that bulletin is issued, if there are questions from the group, we'd be glad to answer those. But we intend for those prior auth requirements to apply to private providers and not to state agency providers. So we're happy to identify any questions related to that. We are taking action on several items related to rehabilitative behavioral health. We're going to be updating rates for master's level and for psychologists for certain RBHS services. We are also adding an additional service in with the RBHS manual. This will be an additional intensive in-home service called Home Builders, primarily geared toward children and adolescents that are at risk of out-of-home placement or maybe reunifying with their family after an out-of-home placement. That's an evidence-based practice. There are pretty prescriptive requirements around who would fit the model. And primarily, we expect bulk of those individuals that would need access to that service will come from one of the health plans and those involved with the Department of Social Services. Yes, we are doing updates to certain codes for rehabilitative therapies. So that bulletin has already been issued as it relates to OT, PT, and speech. So we updated rates related to that. We also issued a bulletin related to certain dental rate increases. So this would impact individuals that access their dental through the ID/RD waiver. We really targeted our dental rate increases for those codes that are either high utilization or really geared toward preventive services. So we really wanted to focus in on those that we felt would help enhance quality of the dental benefit and help with further support of the provider network. Those are the bulk of my updates in terms of the Medicaid agency. I did see one question, Lori, if you don't mind me going ahead and addressing at this time. It was related to the new service that came out associated with the ID/RD waiver. I think this is likely in reference to career coaching. We currently have a public comment out for the addition of this service. I want to be very clear that it is not intended to be a crisis service. This is designed to be a service that can provide training and support to family caregivers for individuals that have an assessed need for behavior supports. So it is providing a support system to caregivers that have family members with challenging behaviors. The career coach conducts a structured assessment yes.
I'm sorry to interrupt you, but I do this all the time. You're using the word career coach and it's actually caregiver coaching. I just want to make sure that people didn't get confused.
Thank you so much. That's the second time I've done this today.
Caregiver coaching, not career coaching, right? Okay, go ahead, Margaret. I'm sorry. It was just the second time and I was like, yeah, I didn't want people to get confused.
I'll be glad to drop that in the chat as a correction as well.
It's okay.
It is caregiver coaching. I'm going to stick a sticky on my forehead. Thank you, Lori. So again, focused on giving the caregiver ongoing support and to help with mitigating the risk of burnout. The caregiver assessment that the caregiver coach completes help inform the development of the plan that's developed. So again, not designed to be a crisis service. This is not designed to be someone that the family calls when there is an immediate need or crisis situation, but an additional support that can be provided for caregivers. So wanted to make that clarification. All right. Those are my updates. Sorry about that confusion on caregiver coaching. I'll turn it back over to you, Lori.
Okay, there was one question in the chat about any answers on the final reconciliation of fiscal year 2023 retro amounts that are still owed. So I thought all the retro stuff was done, but maybe there's one final swoop that you guys were gonna do.
Okay, let me check on that. I do not have an answer right now, but I'll be glad to check and see if we have completed all reconciliations and the dates of those, or if there's anything additional planned.
Okay. And that's the only question we have in the chat. Do we have any questions in the room for Margaret? Perfect. Okay, so we are good. I think I'm next on the agenda. I got assigned a couple of the questions that came in through the email box. One of them was related to the rate increases for the residential habilitation that were published in the June 20th bulletin that HHS sent out. I did send out a memo on Friday. Most of you should have it, that talks about the plan around updating those rates in the TheraP system. We worked closely with HHS kind of ahead of the bulletin. So actually, finally, we are ahead of the rate increases. You guys should have updated authorizations in TheraP today for those increases through for residential habilitation with an effective date of 7/1. TheraP is also working on doing automatic acknowledgement and assignment to programs for those authorizations. As you'll recall in the past, sometimes TheraP really had some hiccups related to, like, if you had one person assigned to 2 programs, they think they have that figured out. So hopefully it will happen. I'm really interested to see if it works out for everybody. But of course, if you see one that's not acknowledged, you can certainly acknowledge it manually. What we're told from TheraP is that they have a plan to kind of run a script all week long so that everything should be acknowledged by Friday. So hopefully beginning on Monday, you can start doing the new, your attendance in the new authorizations. Another question that we got was for clarification about Medicaid denials for people who receive services and the process for those people who lost Medicaid and there's a gap in service. The message that I will give to folks is you guys need to be monitoring that Medicaid eligibility. We obviously have somebody working on that here, right? So you've probably gotten a reach out from Lisa Woods. When they started new look behinds, we started really trying to track anybody who's losing Medicaid and have a plan for getting in front of it. So we get a list from Medicaid every week. We try to work that list. We're doing everything we can to try to keep people from falling out of Medicaid. But at the end of the day, if you have somebody that's losing Medicaid, you need to work to get an authorization for that service through state funding. And DDSN will consider, right, whether or not we are able to do that for people. Obviously residential is a big thing. If you're not going to get paid, we got to figure out what to do with a person, right? So it might be that depending on the funding we have, right? Because this is not just a right now problem, this is a forever problem. Depending on what we have in our budget and the funding we have in our budget, we're going to target the residential folks first, obviously. Services like employment might be something that we're looking at less strictly and whether or not we have the funding to do it. So I think the message to it is get in front of it, not behind it. Don't contact us 4 months after you didn't get paid and say, hey, I didn't get paid. Can you pay me? Because that's really not how the system works at all. It's all around prior authorization so that we know what we've committed as far as funding in the long term. And then the last question in here was about the Waiver Administration Division, and it was a question around whether or not we do quality assurance of their work, and we do, right? We have kind of an inter-rater reliability thing beforehand, and we do some periodic rechecks. I do know that I have heard from people that sometimes it's harder to get stuff approved through one person than another, so. There's a couple of questions. I think these might be for Margaret, so I'm going to get to that because that was all my updates. Who at DHHS approves electronic filing? I don't even know what that question means, so I hope that's for you, Margaret.
And I may need some further clarification. I know there are policies that identify that approval has to be put in place for a certain electronic record systems. I'm not sure if that is the question, but I'll be happy to follow up and get some additional clarification on that question.
Yeah, that is the question, so you can try to.
Okay. Okay, I'll be glad to follow up.
And there's a question around only the residential rates being increased, and there's a question about that whole COLA and not other services getting the increase. So I don't know if you want to look at that one.
Yeah, let me be clear. With the residential habilitation, we did a full review, and again, this increase based on the residential habilitation was the step that we intended to help with direct care workers and supporting the assumption that had been used previously for direct care worker wages. So while I will be clear that we're not putting any mandates for in terms of direct care workers, the ResHab increases as of July 1 were really founded on using an average amount for direct care workers in the rate assumptions to help get to a better place for that direct care worker reimbursement. So that was the piece on residential habilitation. There were some other services that either had not seen an increase in many, many years or by our waiver methodology that we needed to take a look and adjust based on current market rates.
Okay. So Janet, I think you're next on the agenda.
Okay, so I don't have any updates, but I did take some of the questions that were sent in, so I'll kind of go over what those were. So the first question was on the med tech training that Intellectability is creating for DDSN. So again, this is the classroom skills only. None of the, I mean, you still have to do the skills check and the supervision, the oversight and all that kind of stuff. Skills check only. And the question was just for an update. When we started with Intellectability, they pretty much said it would be done December 2023. That did not happen. About a week ago, they said it's probably about 5 more weeks before they finish. They have delivered us a product. A few providers have looked at it. They've provided feedback. We looked at it. We provided feedback. It required a lot of changes in the presentation and some refilming of demonstrations. So about a week ago, they said it would be 5 weeks. So if I had to guess when we'll roll it out, I would say 8 to 10 weeks. Because I don't actually think I'll get it in 5 weeks, but I might. Once we receive it, we will have to do another QA on it. And that means watching every single minute and taking the test just like a direct support staff person would. And some of their questions were wrong that first time around, just say it. Like I failed because their question was wrong. Their answers were wrong. So anyway, that's that. I would expect before the end of the summer that we should be able to have it out. Another question was about with the new regulations that were just updated and approved, will there be any updates in DAHAB standards? We've not started any updates or any changes. We've not drafted any. We've not met to talk about any. What I will say is that all of our directives and all of our standards are always available and open for comment or suggestion. You can go to the website, you can click on the link, and you can send us anything you think we ought to do on any of them. So feel free to comment. We hadn't started on it, but we're happy to listen. There was a question about crisis stabilization and where are we with opening a unit at Midland Center? So about 2 years ago or a little more, there was DDSN had said, we're going to pursue opening a crisis stabilization unit. When we started looking into it, we realized there were a whole lot of issues. Number one was licensing regulations, which basically said crisis stabilization could be licensed to DMH and nobody else. There were a lot of other concerns. We tried to hire a psychiatrist because primarily when we're talking about crisis stabilization, we are talking about mental health services to people who are in crisis. We did not have any luck with hiring a psychiatrist. In March of 2023, DHHS announced $35 million crisis stabilization grant program that was available to hospitals across the state. In January 24, DHHS added coverage for hospital-based crisis stabilization for Medicaid members. Truthfully, mental health crisis stabilization is not DDSN's wheelhouse. It is not our area of expertise. It is not really our mission. People with intellectual disabilities, with ASD, with a TBI, with a spinal cord injury, they are still citizens of South Carolina. They can also have a mental health diagnosis, and they should be able to access the services that all other people in the state can access. There was not any level of expertise that we thought we would be great at delivering. There were too many roadblocks in the way. Having said all of that, we did take the unit at Midlands. As many of you know, it's called Walnut Unit. We did open that unit up as institutional respite for children and young adults. For the most part, that unit has been open for some time now and supporting children and young adults. There are 2 additional units that will be coming online before the end of the summer, 1 male, 1 female at Witten Center, and this is institutional respite for adults. Institutional respite is not having a place to go when you're already authorized for residential habilitation. So let me just put that out there. We're trying to target people who are boarding in hospitals, they are boarding in jails, or they are homeless, whatever those kinds of people are, and there are a lot of them with no place to go. And so that will be the priority for those 2 new institutional respite units. From the first day that we take the first person, there will not be, each unit can support up to 8 people. There won't be 8 people moving in there on day 1. That's just not what the lessons learned with Walnut, that's not a good way to do it. Number 1, too many people at once. Most of them coming to us after some sort of trauma. So it's just not a good idea to put that many people in at one time, so they will be staggered. But again, it'll be effectively 16 more institutional respite opportunities for people around the state.
Just to add, related to crisis stabilization, one of the other things that happened in the middle of us trying to figure out whether we were going to do it or not, right? We tried to hire a psychiatrist for a year. I don't think we ever had an application. And then the second thing that happened was we didn't get funded, right? It was in our budget last year, and it was not included as part of the budget. So that's kind of why, one of the reasons that we shifted and said, instead of trying to do this psychiatric crisis stabilization, let's stand up this unit to do respite kind of in our, what we know how to do and what we've already have a funding stream in order to be able to do.
Janet, I'm just curious, for case managers, is there going to be some type of assessment that they do and send in for somebody to try to get one of those slots? I know you mentioned
Pretty
jail,
much,
hospital, homeless.
there's already a process to request institutional respite, right? And so we have the people who are already on the radar for institutional respite. But I will tell you, for the 16 beds, we have more than 16 people in hospitals and jails. So it's not going to be, maybe once we get those people in and we can start moving people, that there might be like the ability to use these. But the message to case managers is going to be to continue to request stuff the way you request it now, right? So the Walnut folks, that's how they've come in as well. Request for institutional respite, or they end up on the critical, the residential needs list, sorry. They're in critical circumstances, all of these people, right?
Is Walnut full?
So Walnut has been full. We just moved people out last week, but we have people that are moving in this week. So, yeah. So today.
Part of the thought process behind institutional respite, we understand that as providers, you're really taking a chance on somebody, because the people who meet the residential need criteria are not the people that are doing well and sitting around the dining room table with their families and having a meal, right? They are people that are already in life jeopardizing situations. On top of that, the people that are in jail, they're not in jail for no reason. And the people that are in hospitals sometimes are there instead of jail just because somebody made a decision one way or the other, right? They are often people that we don't necessarily know that much about, nor do you. So as a provider, to take a risk on someone that you know very little about, we understand your hesitation. We understand that's a problem. Part of taking people into an institutional respite situation is that we can learn about them. And we can have a behavior support plan, and we can figure out what those antecedents are in most cases. And we can kind of have a little bit more of what works and what doesn't. So when you're taking a risk on one of those people, it's not as great of a risk as it would have been coming directly from the hospital. You got a question?
Yeah, that's true.
Does that mean when we get them from jail, they don't have Medicaid, they don't have waiver? Does that mean y'all can start that
That's
process?
what we're starting, yeah.
At
We start
Walnut,
that with them.
Once we get them from jail, it's hard to get that going, yeah.
Some of the people that we put, like, so we have, the only experience we really have is Walnut, right? And what we have done at Walnut is we've made a very conscious decision about each person. So there are some people, I'll give you an example. We brought one child into Walnut who had been at Cumberland, out of state, for a long time. And we didn't really know a single thing about him. But one of the things we did know was he had all kinds of medical issues and all kinds of doctors in all kinds of places. Well, he was with an MCO. And we didn't want to move him into Walnut and immediately enroll him in a waiver, because then guess what? The MCO goes away and we don't even really know if the doctors and specialists he needs, he can access through fee for service. So we kind of brought him in for a minute, right, before we transferred him. The other thing is, like Janet said, every person who comes into these places, a lot of times we don't know if the long-term goal is a community placement. Some of those people come in, like we've brought people into Walnut and they've ended up being regular admissions in the ICF. So they never kind of hit we've moved them to other units, not regular admission at Walnut. So that's kind of what we're doing. But yes, we're trying to make sure we have stuff in place before it's time for them to go out into the community.
And it's certainly not perfect. There's no one example of one guy came into Walnut. He did fairly well while he was there. We thought that he was ready, and then he moved into a house that actually had a kitchen in it, and the kitchen became a problem.
Yep.
Well, we don't have a kitchen at Walnut,
Right.
right? So there's no food being cooked. Nowhere. We had no idea that was going to be a problem, and it was a big problem. But that, we're not going to solve everything. We're not going to figure out everything, and every environment's different. But we've seen a lot of young adults that get away from their families, and the family's a huge trigger for a lot of the behavior. And when they're away from them, you don't see the behavior they were experiencing at home. We've seen a lot of different things, so we can kind of, at least, we've had them for a minute. And I know that I personally have talked with staff at Walnut and said, don't ever be dishonest when you represent somebody who's supported here. We've also, the staff at Walnut have tried to follow people out as much as possible to kind of meet with the provider who will be taking that person, receiving that person, to make sure that they kind of understand what's been seen, what the plan has been, what has worked. So there's apparently this is a new term for them little children that are smart, a warm handoff. Right. So we're seeing a lot of the warm handoff in reports and stuff now. So the news buzzword, but it's a warm handoff, right? So it's like, we're not just gatekeeping what we know about the person. We're trying to share it, and we're trying to make sure that the people who will continue to support the person understand all of that.
Are any of the ones going to Witten, the adults, are they judicially committed to DDSN?
Some of them. Usually if they're in jail, that's why they're there. They're in jail versus.
But in the Witten ones, I don't know if Janet said this, but we're hoping to do one male, one female.
Yeah, there'll be units, one male, one female.
Because we got a really small amount. There are not as many females, but female placements for behavior challenges is a huge, they're just not any. So anyway, that's what we got going on. We'll keep working through that.
I've got one more question, I think, on that. So as far as when you open the male and the female unit at Witten, and do y'all have any kind of goal as far as assessments before you try to reach out to providers and say, hey, we've got so-and-so, or, put them on the critical list or anything for providers to do an assessment?
They're already on the list.
Okay.
They're already on the list, just their location
will be
on
different.
The list will change.
But you might have more information too that providers can
absolutely
consider.
Absolutely. Right. And I think making a visit, seeing the person, talking to the staff who's had some opportunity to know the person will really be informative. That's what we found, at Walnut. That initially we had to put a group of kids there because of the closing of a placement. So it kind of got stuck really quickly there. But we're starting to see some movement out of Walnut now, which is good because that way we can continue to turn.
None of these units none of the 3 units, the Walnut or the 2 that will open at Witten, none of them are worthwhile if there's no movement out, right? Because it's just opening another unit. And that's been the fear from the beginning. We've had people that stayed a whole lot longer than we thought they would.
100%.
But it was not because of the people or anything other than the logistics of opening a house.
Well, and I think it takes different amounts of time for us to feel like, it's interesting because the staff at Walnut can tell you right away when somebody comes in that they'll say, hey, I think this person's going to go quickly, right? It's just different with different people. Mm-hmm. So. And
there are a few institutional respite beds available throughout the campus.
Yeah.
Throughout the regional center campuses.
Which is why I said if a case manager has somebody that's in need of institutional respite, there's an avenue to go ahead and request that,
So the next question was, do we have any new providers on the forefront that are willing to accept high management, tier 3, 4, and high management? We have not had any applications from new providers that are saying they want to serve that population. There are a couple of existing providers who are growing a little bit, so they're adding some new homes and settings in order to support people. But no, we've not had any new providers coming on with that. Affordable housing options. The question is, where is DDSN on working with HUD to develop affordable housing options for people with disabilities? We are not currently working with HUD. I think that DDSN kind of got out of the push and HUD game a very long time ago, probably 30 years ago. The last houses that were done through HUD, which would have been probably 30 years ago, they still got a 40-year tie-up, contractual tie-up with them. Yeah, HUD is not, I think the Housing Trust Fund replaced HUD as a preferred option or a better option. But, you know, that's not to say you can certainly contact HUD and work through them if you want to create a corporation and stand up houses. So, updates on independent living skills, which is a service that is included in at least 2 of the waivers, and the providers that are already enrolled. So one provider has come forward so far requesting qualification as an independent living skills provider. That provider has been qualified. They've been sent on to Medicaid for Medicaid enrollment. I personally don't know if they've completed that process, but at the end of the day, it's one provider who is yet to start delivering services. There was one question, it was a quality management question that came in this morning, and I apologize. Those kinds of, I need Ann Dalton to answer those questions. She's not available and I didn't get an answer, so we'll try to hold that over till the next meeting to give you an answer.
Yeah, there is one other question about the critical incident system that's for all the waivers. So Margaret, we thought maybe you could best answer that. I don't know if you have that. I think they would like to know a timeline.
Sure. I don't have a specific timeline today, but I certainly will pull that together. So we have been in the course of developing requirements for the new system. That's included participation from folks at DDSN as well as HHS and multiple programs within HHS. We are in the process of finalizing our request for proposal or RFP information. So that will be a procurement that goes out. Procurements can take a bit of time to get over to the state procurement office and then thereafter to be issued. So we are in our final stages of review of that RFP and the requirements. I'd be glad to give an update on our next meeting if I have a better sense of timeline, but there are still several steps remaining in that. I also, while I'm talking, I see an additional question in the chat of clarification for the rate increases. So our current increases for 7-1 do include residential habilitation. They did not include day activity or day services, but we are going to be reviewing all of those for potentially including in our fiscal 26. We're in the process of building that budget request for the next year. So I cannot guarantee timeframes, but know that that is in our discussion in terms of our next budget request.
And then I see there's a question out there about the RFP for the electronic healthcare record. I believe that there will be some movement on that after the end of June. So at this point, it hasn't been scored or awarded.
And if I could, I know Janet mentioned the hospital-based crisis stabilization that HHS has implemented. So all of those locations are in various stages of construction or infrastructure building in different stages. So just know that our first step in that, creating that as an option, was issuing grants to help support the infrastructure. That was funding from the legislature. Identifying the locations and issuing that grant funding. So they are in various stages of implementation. But I think that would be something also to give some intermittent updates. Again, that focused on individuals with a mental health-based crisis in hospital settings. Those settings use what's called the empath model. So an evidence-based model that is designed to provide a setting that is more amenable to crisis stabilization as it relates to mental health crises.
All right. There's a couple of questions, but I'm going to move to Quincy just for time's sake, right? Because we only have a few minutes left, and he's got several of these questions that were sent in. And then if we don't get to the questions, then we'll just try to get something out after the meeting. Is that okay with everybody? All right. Quincy, you're up.
So my first update is an item that was talked about during last Thursday's commission meeting. Back in 2018, Senate Legislative Oversight recommended that DDSN divest itself of properties within the community settings by transitioning current properties to the local providers. DDSN still owns 59 properties spread out all over the state, so we have not listened to that legislative recommendation. So just last week, we went to SPA and conveyed 2 properties to one of our qualified providers. So that leaves us with 57 state-owned properties for which DDSN either no longer receives or will very soon no longer receive reoccurring funds to maintain these properties. So I contacted several providers, engaged their interest in taking ownership of these properties. Some providers were for it, while all of them had a legitimate concern that the properties needed work. And these providers may not be willing to accept conveyance until they were in an acceptable state of repair. So I started putting on my thinking cap and tried to figure out a way to come up with a solution that everyone could agree to. But before I think we talk about the details of that solution, we've got to do an assessment of these 57 properties. We need to know what's happening in them. So each one of them are different, right? Each one of them are different ages. Each one of them have their own issues. So the first step was to procure building condition assessments for these 57 community residences. And so that is currently posted on Skibo as a solicitation for proposals for this assessment. So the vendor that's selected will document and issue an individual report for each existing building element, as well as an inventory of fixed equipment for each property to include items such as the roof, the building envelope, structural, mechanical, HVAC, water heaters, etc., plumbing, supply lines, drain lines, electrical, accessibility, life safety, like the sprinkler systems, alarm systems, and any other condition of concern. So we're going to have them prioritize a list of repairs that are currently needed, as well as a 10-year projection of upcoming preventative maintenances for each building. So we want this report to be a very comprehensive report. Also, they're going to provide an estimated construction cost of the current needs of those projected preventative maintenance items, as well as an estimated construction time for the current needs of each building. So we'll be able to figure out how much and how long it will take to do this. They're going to issue that final report. And once we receive that assessment, we're going to first kind of get together with those 27 providers this affects and go over the report with you. Then we're also going to use this as supporting documentation for us, for the agency to create a capital reserve or a non-reoccurring state funds request when the budget plans are submitted in September. So we're hoping to have this information done by September. Once the funding is received, the plan would then be to complete an MOU with one of those 27 providers in conjunction with that allocation of funding for the deferred maintenance and those construction costs when it's funded by the General Assembly. And then SPA conveyance. So all those three things will kind of happen in conjunction. One will be kind of contingent upon the other. So we received a couple questions about what does conveyance actually mean? So I kind of hate that I can't answer this question right now because I haven't seen the finalized DOA or SPA approved language on the deed. We're still waiting on that information to come from the General Counsel and Department of Administration. I will share that information with the group. That doesn't mean that any of the restrictions that we put on those or the reverter clauses that the Department of Administration, that we're going to use that for all 27 properties. You know, we can bring anything to the Department of Administration. They might not say yes, right? So I think part of that negotiation or part of that, you know, sitting down with the 27 providers, or what do you guys want it to look like? And then we go to the Department of Administration and we give them a proposal for this. And if they say no, then we come back to the table and we talk about it again. So I think it's going to be a fluid situation at first until we can get some of these things in our hands. But I'll pause for questions if you guys have any.
Nancy, what do you think the process is going to be? I know you said that you've got that out for a bid for the assessor basically to come in and do. So what if what they come up with and the provider were not in agreement with what we feel like needs to happen, either the amount or the actual item, in the house, the residents? I know most of them are residents, but there are some that are vocational and then admin, right?
There are a couple of admin buildings.
Yeah.
There are like 4 program buildings. There's some CTH2, some ICS, some CRCS. So I think at the end of the day, we are going to take to heart that the agency does need to divest itself of these community properties. Mm-hmm. So we may start having conversations about, what we do with the individuals that are there since they have a lease. What are we going to do? I think we're trying to go the route that gets you guys comfortable. But at the end of the day, some people might not be comfortable with the property and they might not want to do it. So we might need to start having those conversations about what to do at that point.
So when that assessor comes, you can be there?
Yeah.
And you can point out every...
So they're actually going to come out physically to the locations?
Yes, yeah, pictures.
You can be there pointing at every,
Okay.
ding in the wall, every
Kind of,
water stain,
yeah.
anything you want to point out. You can point out everything in that building to that assessor.
And kind of like when you have an appraisal done, will we each, a provider, receive something to show, based on the assessment, that the assessor?
Yeah, once it's done, it'll come to us, but.
I know for me, but you can betcha I'm probably not the only provider out there of the 27 that their board is going to really want to see what's been assessed, what's been looked at, and then whatever money attached to that. Because if a provider, and I think this was a question too, if a provider decides that they don't want to keep the property, or they take it on, but then in the future they sell it, what type of monies would then go back to DDSN, if anything?
So, and that's what I need to figure out with the Department of Administration. What did they put on the deed, which I don't know yet. We sent them proposed language, but they didn't use the proposed language. I think they used the Senate version of their diverter language or reverter language, their clause. So I haven't seen that yet. So we're kind of waiting to see that. Hopefully by the end of the week. I think Vicki was saying that Linda Gordon at Department of Admin is supposed to send that to us. So we're gonna.
So I think at the end of the day, DDSN can't give away property that belongs to the state of South Carolina. Just give it away. We can't do that. The Department of Administration will put whatever on each of those state-owned buildings that they will decide, and you can decide whether you will take it or not. Whether you accept those terms or not.
Yeah.
But it's not on DDSN to decide to give away state property. Like we cannot make that decision. It's just above us as an agency. The Department of Administration, they can say you can have it, you can use it, and you can do whatever you want to with it, but at the point in time that you get ready to sell it, the Department of Administration will say what stake in that the state of South Carolina has.
Okay.
And I think they have.
But we probably know that though, wouldn't you think, when the property, if we agree the property's conveyed to
Yeah,
us,
it'll be-
we would definitely know the terms of that
Yes,
for us
all
to
of those
take that
terms.
consideration.
We did a conveyance and we think we will have some idea of what terms broadly may look like soon.
Yeah, this was kind of our first go around since the mid-90s, so.
Well, I do like what
Yeah.
you said. You said that the assessor would come out, do an assessment now and then project for 10 years. Like,
Yeah, that,
you know,
it's not just.
you might
gonna be
not
what-
need a HVAC right now, but by gosh, 2 years,
Yeah, exactly.
yeah, so that's
we're-
good to know.
We're trying to, now there may be a long list and it may be over the appraised value and maybe it's not, it doesn't make business sense to do that. We don't know until we see the assessment. We're gonna have the conversation and we're gonna sit down with each of the provider and talk about those properties that they're operating, and then we're gonna, kind of hash it out, what do they think as well. So I don't think we did this last time. I think it was more, hey, we're gonna give you $20,000 and we want you to have this property, and it needed a lot of deferred maintenance, right? There was a lot of things that needed. So we don't want to do that. We also want to get the money as part of the budget request, so.
I was gonna
We need
ask
to
you,
back up
because
for
that's a
that.
lot of properties, 57. So
Yeah,
where would
yeah.
those dollars come?
So we're gonna put that as a non-recurring budget request.
Okay, in your next year's budget.
And it's due in September in like 3 months. So
Yeah.
hopefully we'll have this assessment done so we can have this in there. So we can put it in the governor's budget when we have to have that due in the middle of September.
So what would your long-term goal be in conveying these 57
So
properties?
once it's funded and once we come to an agreement after we have the assessment, we have 2 of the 3 pieces needed, or 2 of the pieces that SPA needs in order to move on. Because we have to have a signed MOU from each of the providers to give to SPA in order to convey, right? They won't accept it based on 36.6 proviso that's out there. So we have to have your agreement. So if we don't have your agreement, then it won't be part of the conveyance package that goes next year when we go to get this done. So.
Have y'all talked about if a provider chooses not to have the property conveyed to them, but still wish to operate the facility? How that would look?
That we haven't talked about, but I can tell you, right now, we're okay with our, funds that are coming in, but at some time, everything gets tight, right? That R word, the recession word comes into play and things get tight. And we might not have the money to give you a $500,000 roof on your administrative building, 10 years from now or 15 years, you know what I mean? So I can't make promises that we would have the funding to be able to do that. And we would much rather it go to you guys and you guys are utilizing and billing Medicaid for those things. So you can prepare for those things based on the rate that you get, right? So.
If we've done inspections by a licensed inspector already, just give those to this assessor, is that the best way to do it?
Yeah, if you've got things, documentation you can give him, to make their life easier, they'll probably be thankful for it.
Would you recommend providers doing anything else to be proactive about this?
Not right now. I think, once we figure out who we award, this solicitation to, then we'll start reaching out for contact information of who's going to be the point person at each of these 27 providers' locations. So we'll start talking to you guys once we have more information on who that vendor is going to be to do these assessments. So, yeah. Trying to think if there's any more questions about this. No, I don't think. Does anybody else have any questions?
So I do have a question.
No, you go ahead. That's
Sorry.
fine. That's fine.
I was just thinking.
Go ahead.
Stop the rapping with me. I wanted to ask you see, now you maybe lose my train of thought, Terry. I know things that we have submitted to DDSN regarding the properties already that we feel like, for example, new HVAC systems and new roofs really come to mind because we really, really need those. In fact, I just did an emergency situation with an HVAC system, but the roofs really need to be replaced. And so I've already sent that. So anything like that, where are we with those requests? Are we just kind of hanging out there right now till?
I don't think I've seen any requests that that I've signed off on for community.
So we've submitted it, you know,
So,
we usually
yeah.
work through Andrew.
Yeah, so
We
if you
send
work
these
through
things to
Andrew, some of those
so-
may not have reached the CPIP level, and he may be in the bid process or getting quotes. It may not have reached that.
Yeah.
We got to go down, or it might.
Yeah, the
have reached
roofs in the
CPIP.
bathrooms, we have submitted, okay? My board's all over the bathrooms wanting to get those renovated. And, you know, I'm just kind of like, I don't know what kind of updates to provide because I don't know where we are with the process. Are we just kind of at a standstill now with this? You know, discussion about conveyance. Because I know those really need to be done.
About the conveyance would change the current flow of business, or at least
No.
it shouldn't.
No, I don't think so. I think we would still.
After the assessment, we'll consider what's in the pipeline.
Yeah.
After the assessment.
Yeah, I think so. I mean, I think.
After we do the assessment, you know, if you need a roof and they do an assessment, the roof's gonna be on it. And then we'll look at it and say, well, we'll finish the roof before this is conveyed, so let's take that off.
We'll mark that off, and that will be.
Because, I mean, I know I got bids for bathroom renovations, and I sent those up, and that's been a while, so,
I'll
you know,
check
we've
with
just
Andrew.
been kind of,
I've got it down. I'll check with Andrew to see where those are in the process. And it may have been, I know at one point that we had talked about a CPIP level for, I think, the DuPonts, and it was
That's
more than
exactly
just
what I'm talking
bathrooms and roofs. It was, I think it was pretty large. It would have had to go downtown to.
yes, it was like
to
125,000, I think.
Yeah, we would have had to go down to JVRC for approval, and that's like a 15-month process in itself.
Yes.
So we haven't gotten approval for anything for, I think, Aiken, but if we went this route, this would be faster than the 15-month approval, I think, it takes to get something through JVRC. So, unfortunately. But I'll speak with Andrew, and then I'll circle back with you and see.
But you do think, once the award's granted, then we'll be having conversations?
Yeah, no, we'll start having conversations.
Okay. I think that's all my questions.
All right.
You can have it?
I received, let's see, a question about more frequent updates on rate adjustments that affect the provider network as it pertains to state-funded services. I know that our desire here is for the state-funded rates to match the Medicaid rates automatically. Normally, I think this is the case when we're doing state-funded services, we always pay the Medicaid amount. Now, do I think that that's going to be there forever? Martin, they could change the residential rates mid-year, right? And so we might not have the money at some point in time to change the state-funded rate, and we may have to ask for that in the budget. So I don't think that it's a one-for-one, but usually when we have the funds, when Medicaid changes the rate, we don't want to pay a separate or lower rate for state-funded than you would for the Medicaid service. So I think what I'm going to do, instead of sending out mass memos every time a rate changes for Medicaid that we have to send out an associated memo, I think I'm just going to put a fee schedule out on our website, and when, rates adjust for Medicaid, then we'll go out there and we'll update the state-funded fee schedule. I think we'll probably put it in the same places on the website that we have, where it's a link that takes you to the Medicaid fee schedule. So just look for that. We'll put a fee schedule out there pretty soon on state-funded services. And the last question was for an update on the budget of DDSN and its funding in regards to consumers who are not SSI or Medicaid eligible but need residential. So thankfully, this was funded in the budget. Although the budget's not yet finalized, the governor hasn't signed it yet. It's been through conference committee, and so they got to present that Wednesday. I think it's Wednesday, or is it Thursday? Wednesday, the House and the Senate come back to vote on the budget. So we should, get that funding in July, and we need to write a policy. We need to write a policy around this new funding, as well as instructions on how to apply, as well as eligibility requirements for this SSI
What's the time frame on that? Because that's a big deal. I'm happy y'all
It's going to
asked.
have to go to policy committee, so it's going to be a new policy, and we're going to have to go through the whole commission route. So
I think it would, in all fairness, I would say around October.
Called fairness in your calendar.
There's nothing called fairness in my calendar. I would talk back to it, but I won't. So honestly, until the budget is approved, or when the budget is approved, and we know we're going to get the money, and then we have the policy, I would think October 1st at the earliest, almost. Because we still got to get the budget finalized. We got to get 2 months for policy committee and the commission, right? So you're almost at October 1st there anyway, because it's July next week, August, September, October 1.
No, I just want to commend you for asking for it.
No one's here to see me. Okay, hang on, I'll be right.
That's not me.
And that's all I had, unless there's questions, additional
Made a
questions.
decision this week.
What'd you say?
Oh, it's just timely, because I was telling, because we've been kind of on the edge, and we've been not really making that a factor, and I just had to quit. We're not going to bring people in now that don't have that funding, because I'm losing too much. I put all this money in them, and they leave, and then I'm out.
You mean like people who can't afford their room and board?
Right, they don't have any furniture, they have nothing. They come to us, and we get them ready to go, get them up and going, and then life happens, and they make other decisions, and I'm stuck with a bill that's not paid. So this would be huge. Because we just this week decided in Lawrence we can't do that anymore. So it's a factor, unfortunately, to admit people. It's awful.
Yeah.
So thank you for seeing that and trying to get that funded.
Yeah, we're doing everything we can on the front end too, trying to get people
There's
ready.
probably not enough money in the budget asked, to be honest, but, and we'll probably, another thing that we need to think about is for people that are going into apartments, if they don't have anything, there's some basic, bed, mattress, pots, pans.
Right.
Yeah, we could.
That's by far the
We
biggest
missed
one.
that. Y'all remember when we had that? We used to
So-
have a little grant
so
for
I
y'all.
don't-
$50 for SLP 1.
So if
Where did
it,
start?
well, here's what I was getting ready to say. If they're going into an apartment and it's a furniture issue, you need to ask about it, right?
Ask us, yeah.
Ask us,
Ask
right?
Who?
DDSN.
Ask DDSN.
But I mean, who?
Either Lori or me.
Lori or Jen,
Right.
okay.
I mean, if it's an
Well, you-
issue
Remember,
of,
I think it used to be around, we could ask for up to almost like 1,500, and we
Yeah.
did a line item budget and sent it to you about startup, like,
the other thing to
mattress and all
know
that.
is if you're interested in supporting somebody, particularly somebody who's in the hospital, and your issue is around room and board payment, you can talk to us about that because some of this money is going to be going to hospitals who are charging us room and board for people. And they're charging us board a lot more than it would be at your place. So, some of it depends on who and the resources. Because I don't want all this money to get eaten up by us paying hospital for board because we don't have anywhere for those people to go.
I already envisioned, they didn't give us everything we asked for. They gave us $1 million of the 1.2, but I already envisioned this, being higher next year and being another ask. We build on top of it,
Sure.
depending on how much we see, how many requests we see from you guys.
I would like to know anytime you turn down somebody because of, that would be something that would be important for us to understand, right? If you say you can't come live here because you don't have the money to pay your room and board, or you don't have furniture, or you don't have, I think that would be very eye-opening for us.
I send you what I've spent thus far to get people floated through my fundraising. I'll give you an idea what it costs.
Do they eventually get their,
The ones maybe, and that's another problem. If you can address the SSI, I hear
It takes forever.
it's
Well, I
like
think-
behind. I mean, we're talking years, not days.
and I think too,
Don't
if we build the policy, the reason I asked about that is what I would like to do is build the policy such that we front the money and then you pay us back. And that way we have the money for somebody else. Because there are going to be some people who, like you said, maybe they move out and you never see it, right? So you can't pay back something you never see. But I think that's something that's important for us to understand as we move forward. So.
Seems to have increased my small sample. I'll try to get you some data. The number of people that are coming in that don't have SSI. That's the big.
Yeah, it's because of disability determination. It's taking
Seem
forever.
to be running into that way more. And then, we're taking a chance on them because we feel like we can get them a job and push them to work. And then they come in and like most people, it's a process. They don't want to work. So it's it's not been advantageous for us to take that chance.
So it'd just be, maybe what I can do is take a look at the residential needs list and try to figure out, there's enough people in there that I might be able to figure out who has SSI and who doesn't, and,
Last time I looked, it was like 60% had it and 40%.
yeah, that's not good.
Yeah, it was like, it was.
Is it, and I don't know that we can affect it, but can we affect, I mean, the issue is the churn, that there's,
I know.
what's going on there? Is it just a federal fund? Well, who does, that's a federal issue, right?
It's a contract that, HHS has with VR, right, Margaret, or am I wrong about that? Disability determination?
Yes, so yes, there is a contract in place for disability determinations with the Vocational Rehabilitation Department. That includes those that have a dual application, both a Medicaid as well as an SSI application. There are some regulations around coordination of those cases. The agency is also looking at some other supports that can be put in place to help decrease the processing time on those claims.
Huge.
Yeah. I think we run into it a lot with people coming out of jail too.
Yep.
Right? Because you go to jail and you lose everything. So even if you had it, there's kind of this whole new up.
Yeah.
And again, it just eats away at state money so quickly. And then that's not even considering what you're talking about, right? Like I can approve state funding to pay the daily res hab rate, but then you're still missing, how do you pay for their health care? How do you get their meds? How do you pay for room and board? All of that kind of thing. So I think we probably need to, I'm glad we talked about that today because that's making me think about some stuff that we probably need to really take a look at.
And I think most of us that are doing anything like that are keeping track of that in case they do, once they do get their benefits, hopefully
Yeah,
they
for
will,
sure.
then pay back to the agency.
Well, it might be good to just, that's something that I think the human service providers could help us with. If you could just do some kind of basic data about how much money is just kind of sitting on the books because of people who are not paying you because they don't have their SSI, they're waiting on a disability determination, whatever. It would help inform, I think. And then again, we can do some looking at residential needs list and do, we've tried to do, some pre-work, but we might need to do it a little more targeted. So, do what we can.
So we're 10 minutes after our end time. Do y'all have anything else?
Yes, I know you said you want to talk about QM, but just, are there any standard change? Because usually about this time of year, or actually before this time of year, we would have gotten like these are the changes that Alliance is going to use to look at you guys from July forward. Do y'all anticipate anything like that, or is it going to stay the same?
They're approved. I just don't know where
The new indicators are approved. I don't think there were many changes.
it's not substantial. There might be a
Nothing
few.
substantial. So I'm surprised they haven't gone out.
Me too.
So I have
So
to.
y'all
check on
haven't
that.
seen them at all?
Mm-mm.
I have not. I won't speak for them.
I know we got approval. It's only been a few weeks. But we
I
got
didn't see the
final
approval.
approval.
My last one, I'll stop, is a document that I have somewhere talking about the ICF rate going back to July 1, 2023. There was a rate change, I believe. Is that correct? Am I right? And if so, will that be changed for us?
The bulletin was from July 1, 2023, yes.
So we will get a catch-up payment for that,
When we do.
Yeah, when we do.
When we do.
Yeah,
and then it will go forward at that rate.
yes.
So that's not that one is not
But it won't
anticipated.
be at that rate. They gotta be careful,
Minus the
Add
fee,
it, right.
minus the admin.
Right, so there's an administrative calculation.
Yeah, there, but
But yes, there is, we will pass that the way we've always passed it, right? When we get it.
Yeah, I've got the memo ready to go out. I just don't have when the retro, usually that memo tells you when the retro is going to be processed, all that good stuff. So I'm just waiting on the dates or to see it in our remittance from Blue Cross. So.
no target on that one just yet. I think you said that. There's no target date right there.
Right now, I don't have anything final of when that rate will show up. Now, that's Margaret, do you know when the gross adjustments for ICF and the new rate will show up?
I don't, but I'd be glad to check on it.
And we're not anticipating a 24 increase. We're talking about the 23 increase. I just want to make sure. Right, so
That's
there's
what I said,
not, right, there's not a 24 increase for ICFs. There's a fiscal year, a July 1, 23, so fiscal year 24.
Yeah.
There's a July 1, 23 increase that has been published in a Medicaid bulletin, but we've not received. We're gonna shore up your rates with that, but we don't have any expectation that there's a July 1, 24 ICF rate increase.
I have not seen anything on
Me
that.
The one I was asking you about was the one that went from 330 to 370.
Yeah.
And
And that's-
it
that's
was,
the one
and it
for
went up to
2023.
540 for institutional ICF.
But just advocating here, we
Okay.
know costs gone up in '24. Health insurance just got approved, was funded in the state budget. I know it doesn't mean it gets translated, I get the new world. But there's cost increases to ask for, I would hope, for '24,
And I know
'25.
we've talked about, and we're kind of in this whole process of, building facility-based rates for each of the facilities. And so I know our pilot, there's a few pilot agencies and our timelines kind of moved a little bit, but hopefully those things will be established. Your costs will be established based on your ICF. Yeah. And so when at the end of the day, when we do transition over to direct bill to Medicaid, your costs will be associated with your facility rate. So hopefully all of that will take care of itself once we move to that. But until then, we're taking out that flat bed fee to remit, as well as the administrative fee for us to do all the billing rules and everything else, so, yeah, and pay for vacancy days. So, yeah.
I'm so glad we came. We just kind of drug this out a little bit, didn't we? With all our questions.
Questions in here, you want to deal with them that way, I don't have to say anything out. So there's a question about the Olmsted decision and whether or not there's any time or resources being allocated towards developing an Olmsted plan.
So that's there was, as part of the proposed legislation.
Right.
In either the House or the Senate version, I can't remember which, there was something about having a state Olmsted person?
Right.
Coordinator, commission, I don't know, somebody who would be the grand poobah of Olmsted for the state. So there was that. DDSN is not moving toward having an Olmsted plan at this time.
So there's a question about whether or not the increase in rates for MTCM and state funded case management are still on the discussion board. So state funded case management, we mirror the MTCM rates. I've not heard of any increase in that rate being proposed, at least for this coming budget year. Is that correct statement, Margaret, or you have more about that?
Yeah, so certainly not one anticipated for July 1st. Of course, we're always reviewing all of the rates and what is necessary in that budget process. So it's never off the discussion. I do not have any firm information in terms of timing and which budget year that may fall in.
There's a question about how to get residential leave, but it's a specific question, so I will respond to you individually. The last thing is, are you going to provide the calculation? I think this is talking about these ICF rates, Quincy.
Mm-hmm.
Are you going to provide the calculation prior to audit so we can record the correct amount of revenue regardless of when the retro payment is sent? I'm sorry,
I think so you guys want to know what
what is the rate going to
What the rate's
be?
going to be? Yeah, I can provide that.
Okay.
Because some CPAs have reached out to me already and I provided that information to them. So
Okay,
if there's a question, they can reach out to me directly and then I don't want to publish the memo because I don't have the dates yet, but I can certainly, if there's a CPA asking to record the revenue, please reach out to me and I've got my standard answer. I'll just copy and paste in there and send it.
all right, everybody understood that? And I think that's everything. Okay. Think we're good.
Anything else? Anybody got anything else? All right. Thank you all very much
Thanks
for
for
your time.
coming.
Thank you.
Thanks for submitting questions
Yes.
in advance.